What if there was a test that you could do that would diagnose pre-eclampsia? And what if there was medication that you could take to treat pre-eclampsia? Would you? Join me in my conversation with Dr. Tania. Find out the details.
I am the Associate Vice President for All Science Partnerships at the Foundation now. I still have my oversight of the metabolic diseases, but I'm also the Director of FNIH patient engagement. So we can make sure that all of our programs are threading in patient voices and community voices.
Sound like you're a very busy woman.
I am, and I'm loving it. It is my favorite thing.
That's great. I think that we're connecting over one particular type of issue that you're currently involved with.
Mm-hmm.
And that has to do with early onset preeclampsia.
That's right.
So if you would, tell us about the work that you're doing.
Sure. So first of all, thank you. It is a great honor to be here. I love conversations like this, and hopefully we get to spread the word and talk about a very painful and difficult disease and something that so many women live with and don't really have that many avenues to talk about or learn about. So I'm really very happy and grateful to you for inviting me for this conversation. So pre-eclampsia is a hypertensive disorder, which means that women, most women know when they're pregnant that you want to watch your blood pressure. And if your blood pressure goes up, you got to go to your doctor. But a very serious form of hypertensive disorder or blood pressure disorder is called pre-eclampsia. It's a subset of hypertension in pregnancy. It's really dangerous because that's when your blood pressure goes very high and your organs start damaging. The mom's organs start damaging, liver and kidney failure starts to happen. And currently there is no real way for us to diagnose this until people start seeing, in addition to high blood pressure, you're starting to see protein in your urine called proteinuria. And when that happens, you know that organ damage is underway because your kidney should not be secreting proteins. And that's when there is an emergency action and moms are put in emergency. And the only current treatment, if you will, for preeclampsia is to deliver the baby in the placenta. So depending on when that happens in pregnancy, this could be extremely dangerous both for the mom and the baby. In fact, preeclampsia is one of the leading causes for mortality in industrialized countries like the United States. So the fact that we don't have a way to diagnose preeclampsia before damage happens, and that we don't really have any way of treating it, is an unacceptable situation. And we've been trying very hard for the past 3 years to build a program that can address the real questions around it and how can we move forward? How can we build a system that can better diagnose early preeclampsia and then hopefully that gets us on the path to new treatment options.
Okay, so with this podcast, I'm hoping that it's getting to pregnant women and people who are non-medical. So if we could just go back a little bit. When you talk about high blood pressure, what kind of numbers are we talking about?
So you're looking at something in the, the normal blood pressure, 120/80. You're looking at high blood pressures in the, well, I don't want to necessarily prescribe that for two reasons. One, because that cut point of blood pressure that is considered dangerous actually is not that uniform across different people from different ethnicities. So I would be a little bit hesitant to give you a number. But if you are above your, over like 120/80 on a consistent basis, you should be very carefully watched and monitored for your blood pressure to be stabilized. Now, one consideration is in pregnancy, you have a lot more blood volume, right? You're taking care of another individual inside your body, and therefore there is all of that blood is still flowing through the same veins, and so the pressure can go up, right? And that is at that point in time, it does, so some heightening of blood pressure is not uncommon, but if it is a consistent high blood pressure, then it is something you want to be watching out, and advocating for yourself. I have high blood pressure, and so the other things, so I'm not a medical doctor, but I actually had preeclampsia myself, so I can speak from a patient perspective. The other thing that happens is, they say if you have preeclampsia, you will have certain, you'll have swelling of your extremities, your hands and your feet and your face will probably swell up, and it's a little subjective, because if it's summer, you're walking, you're standing, this is not something that you can easily identify. The other thing they tell you is you'll have a headache or some sort of blurry vision. Another thing that's very hard to quantify for, somebody who's pregnant and still probably, working or taking care of their house or their children. Some of these things are just, you can also easily sort of clock it to being tired. Just as the second or third trimester of pregnancy, you're tired. So it is a little hard to really identify. And that's why a lot of people go for some time, without really, because sometimes there's no symptoms at all that you can even clock. And so that's why it's very important to go to your regular OB visits and make sure that your blood pressure is being monitored. You're asking the question, hey, what is my blood pressure today, right? And then you are on top of that. And if it sounds to you like the blood pressure is actually going up and staying consistently up, you've got to talk about it with your physician.
I think that's really important when you say you actually ask, what is my blood pressure? And the point that you made, if it's starting to go above whatever your baseline readings were. But I can tell you that as an OBGYN, we do have these numbers in the back of our mind, meaning that if her blood pressure, there's the two numbers, the top number and the bottom number.
Yeah.
If the two numbers are 140/90 or higher, that sends off, alerts.
Right.
If it's 160 or 100 over 100, then we have an issue that needs to be evaluated.
Sure.
In the moment. And so we use those numbers, but you're right, because it can be confusing, because is this a woman that's always had high blood pressure prior to the pregnancy? Or is this something that has developed since she's been pregnant? And that's always a critical factor. And then the other thing that we test for is protein in the urine. We'll ask for a urine specimen and test to see if she is spilling protein in the urine. And you're right. This typically happens towards the end of the pregnancy, where everyone looks puffy and swollen and, the rings don't fit anymore. So it's confusing, but it's more than just being uncomfortable. It can be a medical crisis.
Absolutely. And I think it is very scary, because nobody wants to have to get that diagnosis.
That's right.
But it is so important to advocate, because there are ways that, even though we don't have medications right now to treat preeclampsia, there are ways that you can, with better management, you can have a much different outcome than an emergency running into the hospital and dealing with an emergency C-section that can really save lives. And so it's really important to be vigilant and make sure that you're tracking your blood pressure and asking the question that, is this really
right?
what's going on?
And you said something very interesting on the website for the Foundation of the National Institute of Health, is that it's a two-person disease. What do you mean by that?
It's something that we talk when we talk about diseases. Preeclampsia affects about 7% of women, and now preeclampsia also comes in different levels of severity, right? So you can have preeclampsia that's closer to term after 36 weeks. You still have complications, but that's a little less dangerous than the early onset preeclampsia that happens before 36 weeks. And then you have some more complex versions called the HELP syndrome, where liver functions start to fail. So there's a few different varieties, but in general, you can say, I think that's not an acceptable number, but people think that it is not that many women are not enough people are getting preeclampsia, right? It's not a big disease or a very prevalent disease, but it is a two-person disease because the mom and the baby are both suffering. In the time that you are preeclamptic, the baby can experience lots of distress in utero, in the womb, where they could not be getting enough blood supply because of the high blood pressure. They may not be growing well. And so that's one, is that while you're pregnant and preeclamptic, you both mom and baby are facing the damage from that situation. But even after delivery, in the first couple of years of life, if mom and baby, if there's good support, you had a good neonatal unit in the hospital, baby got support, you got support, you came home. The first couple of years, you still have to be very watchful because the baby and the mom both sustain long-term metabolic challenges from that. So metabolic challenges, so your heart, liver, kidney, incidence of diabetes, things like that are all much higher risk after you've been through a preeclampsia episode, but that risk also is transfers to the baby. So it's a two-person disease because the mom and the baby both have to now be vigilant, and they both, and if you talk from an economic perspective, there is a huge cost on the establishments for tracking, checking, and making sure that two people, not just one, but two people are taken care of in the system from this one disease. And I think it's important to highlight that. It's important to talk about the long-term damage that this can cause to two people.
Right. I think two things don't often get highlighted. And the first is what you're saying. It's two-person. It's affecting not only the mom, but it's affecting her baby at the same time. Worst case scenario, terrible outcome for both. But the idea is to diagnose and not necessarily prevent it, but treat as best we can. And then I guess the other consideration is that it's more than just a blood pressure issue. It affects the entire body.
Yeah.
The liver, the heart, the brain, you name it.
Instances of stroke are much higher in people who had preeclampsia. Their instance of having a stroke are much higher than someone who did not have preeclampsia. But this is also an awareness thing, which is why I'm so glad we're talking about it, because it is scary. It's really scary, but it is something that, in a 20, 30-year-old, women in the 20s and 30s don't get on, watch for things like strokes or, heart disease or because they're young relatively. But the fact that you've had preeclampsia should be an indication to your doctors that they should be watching out for these types of
say that again.
complications.
So if I had preeclampsia during my pregnancy, I'm at higher risk for what?
You're at higher risk for stroke. You are at higher risk for metabolic diseases where, various kinds of kidney, liver, heart functions are compromised.
Years beyond delivery.
Up to 10 years after you deliver the baby, you are still at risk. And again, this is a population that would typically not be on the as a physician, you wouldn't be thinking, if you didn't know that somebody had preeclampsia, if a 32-year-old woman shows up with some stroke symptoms, it's not the first thing that the doctor will go to, right? But that's why it's so important to have the awareness for the long-term risks of metabolic diseases if you had preeclampsia, right? And so that's one of the reasons why we're so passionate about spreading the word and the awareness on this.
Right. And as women of color, we're at increased risk?
Absolutely, yeah. And we don't know if the increased risk is because we already have underlying metabolic diseases that when you're a young person, you may not be tested for, so you don't know. But when you're pregnant and your body is under stress, you develop preeclampsia. So that's the way it's like, aha, now I know that I have underlying metabolic diseases. I don't know. What I don't want to say is it may not be the thing that causes it. It may be the thing that signals that you have metabolic.
That's
right?
an association.
Yeah, it could be they could be co-passengers, right, in the same
Yes.
body,
Yeah.
but they may not be causal. We don't know that for sure, but at least if you had that, one thing you now know is that these are the things you got to watch out for, and certainly much higher presentation in women of color.
Okay, so now I'm a pregnant woman watching this podcast, and I'm worried.
No, I'm sorry.
What should she do, or what can she do?
So the first thing to know is that it's always a good idea to stay on top of your blood pressure. It's easy enough to do. You can do it at home. You can talk to your physician, and you can ask. You should always be asking questions of your OB or your midwife. What is, do I have a risk? What does it look like? Do I look fine? Is there anything here? Just to be an advocate for yourself. Remember that it is scary, but there's been studies that if you find that somebody has a risk of preeclampsia, if they take aspirin, aspirin itself, just by taking aspirin, you can increase the gestation period. So you can increase the pregnancy, or you can, improve the blood circulation and everything else, and it can lead to much better outcomes, right?
And we're talking about a baby aspirin, correct?
Yes, a baby aspirin. And that already works. Now, we don't give baby aspirin to every pregnant person because that can have some other complications, and we haven't fully studied it. But certainly, it is a much better solution if you are, your blood pressure is high or you are going to get preeclampsia. Baby aspirin, great solution, and your doctor will already give that to you, and things will be, you will be in a good. So this is, again, it's monitoring, right? If you're worried, you just monitor it, and that's one. The second is just have when I had a preeclampsia, I was 31 weeks pregnant, and it was hot. It was the month of August. I was standing in a subway, and I was like, this doesn't feel right. But I went to my OB. They said, oh, your blood pressure is high. Why don't you go to the hospital and get looked at? And the first thing they did was they gave me steroid shots, right? So the shots that, the difference between how preterm babies can survive and thrive so well is just the maturation of their lungs that can happen if you give them steroid shots. And so another second thing.
Yeah, it was like a prophylactic injection.
Absolutely.
In the event that you had a premature delivery, the steroid medication would help with the fetal lung development.
Absolutely. And those two things, just those two things, right, can, in the worst case scenario, improve your outcomes tremendously. So if you're scared and you want to do something about it, watch your blood pressure, talk to your care provider, and know that these two things are available to you and should be asked for.
Okay. All right. So getting to the work that you're doing, is there any way to tell if I'm at risk for preeclampsia?
Yes. So there are a few things. First-time pregnancies, because we just don't know. If you've already had preeclampsia, in your first pregnancy, the likelihood of having preeclampsia in your second pregnancy are also high. But now people know, so they will watch you, right? You will get more, the more intense watching from the medical establishment. But for the first time pregnancies, often that's when you see more preeclampsia. So that's one, if it's your first pregnancy. Second, if it's IVF or other assisted reproductive twins, things that may sort of stress the system a little bit. So that's the second one. The third is if you have metabolic factors like you already have hypertension, you already have high blood pressure, you have obesity, you're carrying significantly more weight than you should be carrying at that time, or you have even gestational diabetes, all these things. So if you have diseases that are of metabolic origin, meaning they have to do with diabetes, they have to do with heart disease, kidney, liver, or blood pressure, then the likelihood that will add stress to the pregnancy and could have preeclampsia, that increases the risk.
Yeah. And I would also say that the American College of OBGYN has a list of they call risk factors. And they have
age also, the age is also a risk. So too young and then too old.
Yeah.
There's a
very
framing of
easy
that.
to get on this high risk list. It's being overweight, being of a certain ethnicity,
Yep.
metabolic conditions. I mean, it's fairly easy to get on the list. And if you do make it onto the list, it's segregated by high risk and moderate risk. And then based on how things kind of fall out for you, then you make a decision about whether or not you want to take aspirin. The baby aspirin.
I think you've got to talk to your doctor about it first.
Absolutely.
And then you make it. Yes, but all of this information, if you are listening to this podcast and you're starting to worry, all of this information is available, and your physician will be able to help you make an assessment. Are you a medium risk? Are you a high risk?
Mm-hmm.
There are freely available algorithms that you can put in some values and understand your preeclampsia risk. That's also available. And that's typically what doctors and nurses use to understand your risk level. And then once you have, and based on that, but just knowing, scary as it is, just knowing this information is helpful to ask the right questions. And sometimes it's harder for us to hear things if you don't know what it is that's
right. About. And I guess just to underline the fact, what we're trying to prevent, if possible, a preterm delivery or maternal complications involving, we mentioned them before, stroke, liver disease, and it goes on and on and on. So we're trying to avoid all those things by diagnosing and managing as best we can.
Absolutely.
Okay. So what is the early onset preeclampsia? What do you call this? Protocol?
We should come up with a better name.
Yeah. What is this?
So let's step back, because we say early twice, and there's a reason for it. Early onset preeclampsia is preeclampsia that happens, in 31 to 34 weeks, 30 to 34 weeks, that like earlier. And that preeclampsia is typically more dangerous.
Yes. Oh, let me underline the fact that usually preeclampsia doesn't present itself until what we call the third trimester, the last 3 months.
Yeah.
But early onset is when it occurs less
in the seventh month. Yeah, something earlier. Okay. Right. Yeah, thank you for sort of course correcting that a little bit. Yeah, so 6th or 7th month of pregnancy, you might, if that's when you have the preeclampsia, that's sort of an early onset. If you have it later on, after 35 weeks, so last 2 months of pregnancy, that's late onset. There are many more late onset preeclampsia cases than early onset. Okay, that's first. But when you have early onset preeclampsia, you are at greater risk. That is a more dangerous.
And that's the reason for focusing on early onset.
Yeah.
Okay.
So early onset preeclampsia. So that's the focus population. But what ends up happening is right now you only, first of all, most people hear about preeclampsia when the doctor tells them that they have it, and they have to go to the hospital, right? But even otherwise, most people find out we don't know if somebody has preeclampsia until they've already had it, because,
Right.
like I said, we measure protein in the urine as a measure. So what we're trying to do is we want to see if in first trimester, so that would be 11 to 14 weeks of pregnancy. Can we, from a blood sample from that window of time, can we predict that somebody is going to get early onset preeclampsia?
Mm.
Can we predict early in pregnancy that somebody's going to have early on?
Got you.
That's where the word early comes twice, and I think we should come up with a better way of saying it, but I just wanted to clarify that.
Yeah.
And the reason we are doing the test earlier in pregnancy, in first trimester, is at that point, none of the damage has happened, but you have identified a higher risk patient of somebody who's likely to develop it. And so that has consequences to many things. It has consequences to early diagnosis. So you've diagnosed that somebody is going to get preeclampsia in the first trimester, which means you can get put on your aspirins and you can be watched closely by a maternal fetal medicine specialist, or there are different types of support systems that you can have that can really support you through the rest of your pregnancy before you start to display organ damage. When I say your mom starts to display any difficulties in organ damage, so early diagnosis, of course, very helpful for all of the simple interventions that we can do. But the other thing that we were really interested in is we don't have any medicines to treat this, right? Aspirin can delay it, but there is no medicine that actually can treat preeclampsia. And that I just want to take a segue, if I could, and talk a little bit about drug development. So what happens is when we want to put a new medicine on the market, we do what's something called a clinical trial or a clinical study, which is to test if a new medicine is working. And the way you test it is you bring people into a study and you give some people the drug that you're testing, and some other people get what's the standard of care currently, and then you see if the drug has a better impact than the people who are not getting that drug. The problem that we currently face is that we don't recruit pregnant people to clinical studies. And if you think just a little bit on that becomes obvious. You don't want to put a person who's already under a lot of strain due to pregnancy and an unborn child under a medicine that we don't know what's going to happen, right?
Absolutely.
And so for good reason, pregnant people are not enrolled into clinical studies. But the flip side of that is, how do you get new medicines for diseases of pregnancy? Or for anybody who's been pregnant, most medicines that you normally would be on, you have to get off of them when you're pregnant because they have not been tested in pregnant conditions. So it's an issue, right? Like, we don't know. And so what we were hoping is that if you can tell with a strong probability, you have an 80-90% chance by looking at your first trimester blood, I can say that you have an 80% chance you're gonna get preeclampsia. Now you can make a case for benefit risk in putting that person in a clinical trial. That patient or that woman is now informed, understands that there are very strong risks, and there's a potential test medicine that can help them, right? So it sort of shifts the benefit to risk ratio. What you don't want to do is put somebody who's not going to get preeclampsia in any form of risk for a medicine that they may not benefit from.
Got you. Okay, I got.
That's a little complex.
I got
That's a little
three
much.
questions. I
Yeah.
got three questions for
Yeah.
you. Let's
Ma'am.
go back to the testing, okay? Are those tests available now? And how good, how reliable, or predictive, I guess is a better word, how predictive are these tests for early onset I guess I have three questions, pre-eclampsia, and if I test negative for early onset, will I also be negative for late onset?
Very, very good questions. Let's break it down. The first one is, are these tests available? So there are two or three companies that have made, so one more step back. We actually know, science has told us that there are two proteins that are made by the placenta that are only present when you have a placenta, so it's only present when you're pregnant, right? So that's easy. And at a certain level, if they're not being made at a certain level, their concentration is low, it has a strong link to preeclampsia. This has already been shown in animals and in humans. Based on that, there's a couple of companies that have built these assay kits or tests. So you just take the blood and you test for the level of that protein in the person. Now, these proteins are already made in the first trimester, so you can start to get that information. So we have two proteins, and we know that at a certain threshold or a certain level, if they're below that, then there is an issue. This has been tested in second and third trimester. That threshold level exactly for first trimester is not as well known, but it's something we're working on. Regardless, those kits are available. They're made and they're actually used in some parts in the European Union already.
And are they more predictive than just going by risk factors?
Yes.
Okay.
Yeah. You can add them to the risk factors and make it even more predictive. But the issue is that we cannot currently use those kits in the United States because they're not approved by the FDA.
Oh, okay.
So part of our work is to make sure that we generate enough data in a US-centric population, which has two factors, right? We have much more ethnic and racial diversity. And second, we have very different sort of metabolic conditions because our food habits are different, our living habits are different, our environment is different. So in a US-centric condition, with all the complexities and heterogeneity that we represent, can we establish what that threshold for that protein is? Because we're talking about thresholds of a protein. We want to make sure that we're dealing with, that's why our study has 25,000 samples, because we need a big sampling to be able to, with some confidence, establish what is the threshold.
So if I'm understanding you.
And you had two more questions that I want to get to, but let's go down this road first. Yeah.
I probably will forget those questions, but that's okay. You are not questioning whether it has a predictive value. The study that's being done currently in the United States is to determine the most appropriate threshold level for
our population.
For our population.
And in the first trimester. So those two are very for our population and in first trimester.
And you're fairly confident about these two blood tests because they're being used elsewhere.
Yeah, they have been around for a while. People have been doing this. This has been these types of things. There are companies that are already targeting those proteins as a therapeutic. If you actually, can destroy one of those proteins, maybe that improves the outcome. So this is literature that has existed for a while. Most of the problem has been in sort of deployment of that information into something that can be accessed and used, especially in our country.
Okay. Now, this is the big question. We do the test, we get the threshold level.
Yeah.
We see that there's a real benefit because you can diagnose this early onset preeclampsia, which can have dire long-term effects for both mom and baby. And that justifies giving the medication to a pregnant woman, something we never do. Give
Right.
medication,
Right.
give medication to a pregnant woman.
But before we can give that medication to the pregnant woman, we actually have to confirm that that medication works. We are so far behind.
You have to do
Even
testing. You have to do
test.
testing. And that just raises so many issues.
Yeah.
You know, it's like if you're that pregnant woman,
how are you going to make that choice?
Are you going to take the medication? And like you said, it's not just the mom, it's what are the long-term effects?
Yes.
That's an interesting question.
It is very interesting. And it is an ethical dilemma that we have struggled with for a long time. And anybody who's, been pregnant and had a chronic condition that they had to manage during pregnancy has struggled with whether they stay on the medication that works for their body. Is it going to hurt the baby? So this is not something that's uncommon to us. We deal with it.
Right.
But we have to, but the fact of the matter is, pregnant women of color are dying at 3 times the rate of white women because of this condition. We don't have solutions. So we have to start to at least establish the parameters that lowers the risk.
I know, but there's such a horrible history of people of color feeling as though they're being experimented on.
Of course.
And so it's a real dilemma.
Absolutely.
It's an interesting question. And we are in dire situations when you say now, no matter what you decide the maternal mortality rate may be in this country, there's still a vast difference between Black non-Hispanic and white non-Hispanic. No matter what numbers you look at, there's like almost three times the difference in terms of maternal mortality rate.
It is true.
And so then do you go to that Black mom and say, will you take this medication? Interesting. That there are a lot of factors to weigh.
It is, absolutely. And, it is something that just to even, just being a mom is a difficult thing always, to make difficult decisions all the time. But even if you were to just put your body through a clinical trial, it is a challenge, right? Like, because there is inherent and validated mistrust. There is not, people, so as you talk about, how do you build trust in science and how do you diversify clinical trials to test medicines on all bodies so they can be, given to all bodies without with a good understanding of risk and benefit. It is a challenge, and many people are doing great work. There are many Black women leaders who are actively working on spreading the word to make sure people understand the value. What is a clinical trial? If you're getting medicine, you're not getting a sugar pill. You're getting the standard of care that is currently what people are doing, and then the medicine is just supposed to show a slight improvement over that or great improvement over that. But you're not gonna, there's many ways to talk about it. And so culturally sensitive conversations are just so critical. But there is really, where we are right now is we are struggling because we have to make medicines that work for everybody. Mm-hmm. And we are not, because of this sort of our sort of very sort of troubling history in this country, we are not able to test those medicines during clinical trials on all bodies, right? Because when you do a clinical trial, you're testing on a subset of people. If you can't test something on a lot of people, and if that subset of people is not representative of different ethnicities and backgrounds in this country, we are just testing it on a subset of people, and then we're trying to prescribe it to a lot of folks, and that's not good either. And so these are all the struggles, right?
Really interesting question.
Another day we'll talk about this.
Yeah.
At a larger scale.
So I am glad that you're the one in charge.
Oh, I'm not by far, but I'm trying.
I'm glad that you're a woman. I am glad that you are a mom. I am glad that you are a woman that actually experienced preeclampsia. So you really know what
Yeah.
you're dealing with.
But I'll tell you, I was so fortunate because I'm a scientist. I can, clearly, I'm not shy to talk and bring things up. I don't get easily overwhelmed. But I'll tell you, it was a terrifying time. I had no idea what was happening,
Mm.
and I was at one of the best university hospitals in the country.
A
I lived in New York
PhD, a
City.
PhD trained
Yeah,
scientist.
I had
Yeah.
all of the things, and I had a very supportive partner who was also advocating for me the whole time. So in spite of all of that, right, the impact that it had on my life and continues to have on my life is huge.
Mm.
And when I talk to, is in the course of setting up this program, when I've talked to women, and almost always women of color who have dealt with this, um, there are many, many levels in which the system hasn't supported them. And a big part of that, first, is that we just don't have enough education around this. People don't talk about it. Nobody, if you're pregnant, somebody should tell you the first thing, this is something that could happen. I know you're scared, watch out for these things, right? But for various reasons, the way there's very little awareness and cultural sensitive awareness to talk about this, right? That's one. And the second is, people go to the hospital, they complain about a headache, and they get turned away. I'm like, you're gonna be fine. You're pregnant. It's hot outside. You can be fine. No, there's all of that too. People just don't take uh, you know, sometimes women and often women of color seriously. And this is a big problem too. So we are dealing with a cultural construct and, a sort of a biological construct, both of which are, not helping us. So we got to help each other, right? That's how I feel.
So the clinical trials have not started yet, correct?
No, so there are, let me rephrase it. There are some medicines that people think are going to be good in this disease, right?
Mhm.
But again, the whole, like, how will we design a clinical trial is challenging. So that's where sort of things have come to a halt. There is one company, and there's probably more than one, but one that I'm aware of recently, that is doing a clinical trial for a mRNA type of a technology that's going to attack one of the proteins that I was talking about that we are measuring as a detection, right?
Mhm.
But actually, if you manipulate that protein level, that can also have a positive impact, or at least that's the hypothesis. So there's a couple of things happening.
These are not clinical trials, are they? Are these being done?
There's a small clinical trial, I think, in the works. I can send you a link. I gotta go back and look at where they are in their work, but I can certainly send you the link.
Okay. Wow, this is something to definitely keep abreast of. I really appreciate your taking the time. Very informative. Thank you. Thank you so much.
Absolutely. No, we're so happy to talk to you, and I'm glad you're doing the work you're doing to get the word out. And
yeah, I
happy to
think
talk
it'll
anytime.
just lead to more conversation and more discussion.
And more questions.
And more questions. Yeah, more questions so that people can appreciate the full spectrum of the issue, and all the different aspects that need to be addressed if it's going to be effective. So.
And I was going to tell you one thing I didn't mention is one of the things that we do at the foundation is we build these partnership structures, right? And so in addition to the best doctors in the field who have done the science on this, plus all of these patient samples or pregnant women samples that NIH funded the collection of and are being donated to the study, and all the companies who are running the kits are donating their kits. We also have the FDA, the Food and Drug Administration, also wants to help, right? They also want to find a way that we can get there. So we are getting early input from all of these different stakeholders. All of these different people are thinking about this problem from different angles.
Absolutely.
And patients, lots of patients who are talking to us about what's important to them. So this is really, like, I feel so good about the fact that all of us think we know what needs to get done, but truth is somewhere in the middle of all of our opinions. And so I'm very grateful to So the many people, I would just want to tell you and leave your listeners with the thought, so many people care about. So many people care about finding a solution that can help with early diagnosis and bring new medicines to market. And we understand the ethical and political and social and emotional challenges around it.
So
And we're
many.
not trying to take it like it's not a light endeavor, right? It is something that is being done very intentionally. I want to say that so many people in the Food and Drug Administration at NIH, in the medical community, and in industry, in pharmaceutical industry, are really putting their minds together to solve this problem.
What if there was a test that you could do that would diagnose pre-eclampsia? And what if there was medication that you could take to treat pre-eclampsia? Would you